Here are the imaging of acute pancreatitis. Simple KUB, X-ray, the simple X-ray, is not useful for the diagnosis of pancreatitis, but it can help to rule out perforated ulcerative disease. Nowadays, contrast-enhanced CT is currently the best method for evaluation of the pancreatic disease. Assessment of the disease. Nowadays, there are many assessment methods like ransom criteria, PANCREAS2, and modified CT severity index, but I have to say none of them is perfect. Pathophysiology. The local injury induces the release of TNF, tumor necrotic factor alpha, and IL-1, interleukin-1. Both cytokines produce further pancreatic injury and can amplify the inflammatory response by inducing the release of other inflammatory factors, which can cause distal organ injury. The abdominal inflammatory response is responsible for the mortality seen during the early phase of acute pancreatitis. Treatment of AP. First, aggressive fluid resuscitation with isotonic crystalloid solutions. The rate of the administration should be individualized based on mental status or urine output. Complications of AP is hypoxemia caused by the acute lung injury. And for some severe case, because of the pain, it is also essential to provide effective analgesia. Complications. First, sterile or affected peripancreatic fluid collections. For the symptomatic or affected cases, the percutaneous drainage can be performed. Necrosis and infected necrosis. Nowadays, we can perform open or laparoscopic approach, even plus endoscopic assistant necrosectomy. For the pancreatic pseudocyst or ward-off necrosis, the transluminal or laparoscopic anastomosis may be help. Chronic pancreatitis. From the two pictures, we can see, from the first one, we can see the irregular dilation of pancreatic duct, and also there are many calculus in the branch. Last, we will talk about the pancreatic neoplasms. The pancreatic neoplasms usually presenting symptoms frequently, like jaundice, weight loss, abdominal pain, nausea, vomiting, pruritus, fever, even GI bleeding. Lab findings. Lab evaluation of neoplasms should include hepatic function evaluation, coagulation profile, and nutritional assessment. CA19-9 is the most sensitive for pancreatic adenocarcinoma, we call that PDAC, with a sensitive of about 80%. But the CA19-9 also has its limitation. It is a false evaluation caused by biliary obstruction or inflammation. Sometimes it can mislead the diagnosis. Here are the pictures about the neoplasms of pancreas. The first, we can see the dilated common bile duct and the dilated pancreatic duct. There are two ducts. That's the obstructive jaundice. The second, we can see a non-irregular heterozygous neoplasms. It's the distal carcinoma of pancreas. The right picture, we can also see a mass at the head of pancreas. Benign tumors include IPMN, intraductal papillary mucinous neoplasms. We can see the dilation of the main pancreatic duct. The second is mucinous cystic neoplasms. We can see a cystic neoplasms at the tail of the pancreas. Also, there are septic appearance. The last one is SPT, solid papillary tumor. We can see there is tumor at the ancillary precise, also calculus there. We will talk about surgery treatment of the neoplasms. For the tumor of the head and the ancillary precise of the pancreas, we usually perform Whipple procedure, also called pancreatical duodenectomy. Well, if the tumor locates at the body and the tail of the pancreas, we will perform distal pancreatectomy. That's all. Thank you.